Assalamu alaikum. Welcome back to my channel. What if the heart is squeezed so tightly by fluid that it can no longer pump effectively? This life-threatening condition is called cardiac tamponade, and echocardiography is the key to recognize it in time. Today we will uncover the essential echo signs you must never miss. There are multiple echocardiography features described in patients with hemodynamic compromise and frank cardiac tamponade. It should be emphasized that cardiac tamponade is a clinically diagnosed. Echocardiographic finding may suggest a hemodynamic abnormalities that may be the substrate of tamponade. But echocardiography abnormalities alone do not establish the diagnosis of clinically cardiac tamponade. One of the earlier signs of cardiac tamponade was a swinging heart detected on either M mode or two-dimension echocardiography, as you see in the video of two-dimension echocardiography. Detections of swinging heart is simply a marker of large pericardial effusion in which the four cardiac chambers are freely to float within the pericardium space in a phasic manner. A large pericardial effusion is more likely than a small effusion to be associated with elevated intrapericardial pressure, and hence the relationship between a swinging heart and a hemodynamic compromise is indirect rather than direct evidence of elevated pressures. Because the cardiac position varies within the pericardium from beat to beat, its position in relation to an electrocardiography also varies. This is the mechanism of electrical alternance seen in large pericardial effusion. More specific signs of hemodynamic compromise have included direct evidence of actual elevation in intrapericardial pressure, diastolic right ventricular outflow collapse, exaggerated right atrial collapse during atrial systole are well validated as signs of elevated intrapericardial pressure. The earliest description of diastolic right ventricular collapse was obtained using M-mode echocardiography, in which a posterior motion of the interior right ventricular wall was noted in diastole. As you see in the image, the aortic valve closing time, the right ventricular interior wall is dipping toward posterior side. This observation was subsequently confirmed using two-dimensional echocardiography in patients with elevated intrapericardial pressure. Intracavitary cardiac pressure may transiently fall below intrapericardial pressure in early diastole, and hemodynamic compressions of the more distensible structure will be seen. As you see in this video, anatomical and experimentally, the right ventricular outflow tract is more compressible area of the right ventricular tends to collapse. In early diastole, immediately after closing of the pulmonary valve, the right ventricular outflow tract will paradoxically collapse inward. This is indirect evidence that intrapericardial pressure exceeds right ventricular diastolic pressure at this point in the cardiac cycle, and hence the underlying substrate for tamponade is likely to be present. Collapse of the right ventricle is often best appreciated in the parasternal long axis and short axis views, but occasionally can be appreciated in the apical four-chamber view when collapse extends from the more compressible outflow tract to the body of the right ventricle. As you see in this image, the mitral valve is open and the right ventricular is collapsed. This is the diastolic collapse of the right ventricle. When the mitral valve is open, so this is the diastolic phase, and look at the right ventricular free wall, this is collapse and diastole phase. This is the evidence that intrapericardial pressure is elevated more substantially. As a corollary of this, exaggerated right atrial collapse is seen, which is an indication of impended right atrial filling. This occurs within timing opposite that of right ventricular collapse. It is identifiable on two-dimension echocardiography, typically from the subcausal or apical four-chamber view. Because the right atrium normally contracts in volume with atrial systole, the degree of right atrial collapse must quantify with respect to either the magnitude of collapse and the duration for which it remains collapsed. Right atrium collapse occurs immediately after normal atrial systolic contraction. In the presence of marked elevation of intrapericardial pressure, the right atrial wall remains collapsed throughout atrial diastole and buckled inward, reversing the normal wall curvatures. In situation in which a localized effusion is resulting in hemodynamic compromise, one may occasionally encounter isolated compressions, usually diastolic, of the left atrium or left ventricle. Doppler interrogation can be used to evaluate mitral and tricuspid inflow and aortic and pulmonary outflow. An exaggerated phasic variation in flows can be documented with respiration. There is a phasic variation in intrathoracic pressure which augments tricuspid flows in inspiration and decrease it with expiration. Reciprocal changes are seen in mitral inflow. Under normal circumstances, peak velocity of mitral inflow varies by 15% or less with respiration, and tricuspid inflow by 25% or less. As you see in this video, the tricuspid inflow, the largest one is the expiration, and the smallest one is the inspiration values. 0.97 expiration and 0.39 is inspirations. So the variation is greater than 25%, as it is approximately 200% variation and the tricuspid valve. Variations in peak velocity and time velocity integral of aortic and pulmonary flows profile normally is less than 10%. In the presence of hemodynamically significant pericardial effusion, exaggerated ventricular interdependence develop. Respiratory variation in filling is exaggerated above these threshold, as in this case you see this is the variation is about 200%. So this is large about that 25%, and as a consequence, respiratory variation in outflow tract velocities and time velocity integrals is likewise exaggerated. These Doppler findings are the corollary of a pulse's paradoxes. Pulse Doppler imaging of superior vena cava and hepatic vein flows can also reflect the elevated intrapericardial pressure and altered filling patterns. Normally, vena cava flows occurs in both systole and diastole and is nearly continuous. In the presence of elevated intrapericardial pressure, flow during diastole is truncated as you see in the image, and the majority of flow into the heart occurs during ventricular systole. Hepatic vein flows pattern may also reflect the exaggerated respiratory pace dependency of right ventricular filling. As a general rule, Doppler flows profile of vena contracta, vena cava flows are confirmatory of the hemodynamic abnormality and are rarely used as stand-alone diagnostic findings. There is a well-defined and predictable hierarchy with which these findings occur in hemodynamically significant pericardial effusion. These have been well defined experimentally and fit the well-known physiology of the disease state. Typically, the earliest feature to be noted is exaggerated respiratory variations of tricuspid inflow, as I told earlier. Subsequently to the pathology, exaggeration in mitral inflow pattern can be noted. Abnormal right atrial collapse typically occur at lower levels of intrapericardial pressure elevation. Then does right ventricular outflow tract collapse, and right ventricular free wall collapse is seen only later in the development of elevated intrapericardial pressures. It should be noted that with milder elevation in intrapericardial pressure, right ventricular diastolic collapse may be seen in expiration but not in inspiration. When right ventricular filling is augmented, intermittent collapse is often best documented with the M-mode echo when intrapericardial pressure is elevated and consistently exceeds intravascular pressures. All these findings will be present simultaneously. There are several instances in which these changes may not be seen. In general, only underlying disease which interferes the normal basic ventricular interdependence may reduce the magnitude of both clinically findings and echocardiography. Abnormalities in cardiac tamponade. Significant left ventricular hypertrophy resulting in a relatively fixed rate of left ventricular filling may reduce the degree of ventricular interdependence with respiration. Respiratory variations of ventricular outflow and stroke volume is consequently pulsus paradox may be reduced. In such instance, it is not uncommon to visualize varying degree of global cardiac underfilling with relatively small ventricular and atrial chambers, but without a dramatic variation in filling. The most common is probably a patient with significant right ventricular hypertrophy, usually due to the pulmonary hypertension. And that time, the thick non-compliant right ventricular wall is not compressed by a relatively modest elevation in pericardial pressure seen in early diastole, with active left ventricular relaxation and both clinically and echocardiographic signs of compromise may be minimal or masked. Often relatively hypotension is present but without pulsus paradoxes, thickening of the ventricular wall due to malignancy and overlying inflammatory response or an overlying thrombus in hemorrhagic pericarditis may have the same effect. Similarly, because the magnitude of ventricular interaction is directly related to ventricular volume. These signs may be absent in low pressure tamponade as may be seen in hypovolemic patient. Cardiac tamponade is a true cardiac emergency and recognizing its echocardiography signs can be the difference between life and death. If you found this lecture helpful, don't forget to like and share and subscribe for more in-depth cardiology insight from our pericardial disease series. Thank you for watching.